Good evening, everyone. How are you all? Good. All right. So tonight we are going to do a couple of other topics. So these are all our left out sessions that we are doing at the moment. So we do the hematology and renal system together because there is not too much to discuss from here, and these are not super important for exam as well. But again, you need to have a basic idea about hematology. The renal system is already half done with lots of other discussions that we have, and we'll finish the rest of it today. Okay, so let's start with the hematology. We don't have any notes for it because we follow John Murtagh entirely for this session. So you'll be having both hematology as well as the renal system, all from John Murtagh. So you'll be needing to use John Murtagh a little bit for this class. So, so starting with hematology, so for John Murtagh, you have got two chapters. One is chapter 13, which is anemia. And then we have got bleeding and bruising, which is chapter 29. So this two is your main hematology chapter from John Murtagh. It doesn't have a lot of discussion about leukemia, lymphoma. There is a bit discussion in malignant conditions. So in chapter 17, we will discuss that from there. All right. So let's start with anemia. So all of you know what is anemia, right? So anemia means a reduction of red blood cell number or hemoglobin level below the normal reference level. So basically anemia means low hemoglobin. And by low hemoglobin, it means that for men, it is less than 130 gram per liter. And for women, that is 120 gram per liter. That's anemia. So most common cause of anemia in Australia is iron deficiency anemia. So almost 20% menstruating women can have iron deficiency because of excess blood loss. So you don't need to remember the normal reference because that will be given in the exam. So anemia patient presents with fatigue, tiredness, getting ill, sometimes because of lack of blood or hemoglobin. The heart starts to like pump more, causing the tachycardia or palpitation. And they can also get shortness of breath with exertion. So most of the anemia patient can be asymptomatic if the hemoglobin is not too low. But when they become symptomatic, their main presentation will be tiredness or fatigue, muscle weakness, headache, lack of concentration, very commonly dyspnea on exertion or palpitation. And there are lots of non-specific signs which you can go through in your own time. Now, when we come to classification of anemia, we follow this division based on the red cell size. And the red cell size is mainly measured by mean corpuscular volume. So MCV is the measure of size of each of the red blood cell. In a normal red blood cell, the MCV should be between 80 to 100 femtoliter. That's normal. That's why it is called normocytic. Some patient can get small size red blood cell, and then that will be less than 80, which is microcytic. And some can have more than 100, which is macrocytic. So these are the most common division of anemia: microcytic, macrocytic, and normocytic. Now coming to each of the division has some specific cause. Like microcytic anemia, the most common cause is iron deficiency, followed by thalassemia. Then it could be anemia of chronic disease. Macrocytic should be B12 deficiency. So it is wrong over here. It should be macro. So macrocytic B12 deficiency, folic acid deficiency, sometimes myelodysplastic syndrome, And some other conditions like alcohol, liver disease can cause it. Normocytic. Normocytic anemia can be due to most of the time if a patient is losing blood from somewhere, so hemolysis, then aplastic anemia, hypothyroidism, kidney disease. This can cause normocytic anemia. But your main thing that you need to know is micro and macro. Normocytic anemia usually doesn't come in exam. Now, coming to the microcytic anemia, the main cause of microcytic is iron deficiency and hemoglobinopathies or thalassemia, right? So iron deficiency anemia is the most cause of anemia worldwide, and it is the most common cause of microcytic anemia as well. So when a patient develops microcytic anemia, you need to first find out from where they are actually having the deficiency. So the deficiency can be patient is having lack of dietary intake, like someone who is a vegetarian, they don't take that much of a meat, and without meat, you don't have enough iron. So vegetarian can get it. Then patient who is having excess blood loss, could be menorrhagia, could be gastrointestinal bleeding, could be frequent blood donation, even sometimes malignancy. Physiological requirement like pregnancy and then adolescence, they usually have increased requirement of iron. Malabsorption, so patient having enough iron in the diet, but they are not absorbing it, like they have celiac disease. So even though they are having enough iron in their diet, but their gut is not absorbing the iron, and that's malabsorption. So when we get a microcytic anemia and we check the iron, and the iron is also showing low, the next step would be to check for these causes. Is there a lack of dietary intake? Is the patient bleeding heavily? Is the patient having malabsorption? Okay. So clinical features. So definitely the patient will have features of anemia, as we already know. And when we do the lab finding, microcytic anemia will be there. And the main finding in iron deficiency is serum ferritin level. So ferritin is the storage form of iron. So this storage form of iron will be low. Remember, serum total iron can be low in a lot of other conditions. Someone who got a recent infection, their serum total iron can be low. But the main thing that you should look for if you're trying to rule out iron deficiency anemia, that is serum ferritin, and that is the storage form of iron in our body. They can also have increased transferrin level. So why we get increased transferrin level? Because transferrin is a protein in the blood which is supposed to take the iron. Okay, so iron in the blood will be carried by the transferrin. Now, if there is lack of iron in the body, what will happen? So now more and more transferrin is alone, not getting bound with the iron. So that's why you can find out that there is increased transferrin level in the body, and there is decreased transferrin saturation because there is not much of a iron that is binding with transferrin, because now more and more transferrin is available in the blood, causing the increased transferrin level. But because iron is not getting attached because it's low, the transferrin saturation is getting reduced. Okay, does it make sense for everyone? Okay, good. So you get microcytic hypochromic red cells. So MCV will be low. In iron deficiency anemia, you also get MCH and MCHC low. So MCH is the mean corpuscular hemoglobin, and MCHC is mean corpuscular hemoglobin concentration. So MCH and MCHC, so it's mainly detect like what is the concentration of hemoglobin in red blood cell. So that because hemoglobin is already low, so the concentration of hemoglobin also will be low. So that's why MCH, MCHC is also low in this patient. Okay, so that's mainly the finding that you'll be looking for. This kind of patient, when they are iron deficient, you can get some other finding like angular chelosis, glossitis, even sometimes koilonychia, where you get a like a spoon-shaped nail. Okay, so these are some of the other finding of iron deficiency. So what will happen that, let's say you have got a patient who is feeling tired, fatigue, and then you've done some blood test and the full blood count showing the hemoglobin is low. Your next step would be to find out, is it microcytic, macrocytic, or normocytic anemia. So you check the MCH, MCHC, and MCHC. So when you check that, you will find out microcytic hypochromic anemia. So when you get microcytic hypochromic anemia, your next step is doing the iron studies. So you did the iron studies. Iron studies shows the patient having low ferritin. That will confirm your diagnosis that this is iron deficiency anemia. But let's say you did an iron study, but it came as normal. Then the next step would be to check the hemoglobin electrophoresis to rule out thalassemia or hemoglobinopathies. All right. So that is your step-by-step investigation. Now this comes in exam. So they give you a scenario and they ask you what will be your next choice of investigation. Always remember, many times, if we get iron deficiency anemia in a patient above 50, we are always concerned that if they are bleeding from their bowel, bleeding from their gut, or if they're having a bowel cancer. Because if you remember our GIT class, one of the presentation of right-sided cecal or colon cancer is iron deficiency anemia. So if it's a more than 50-year-old having a recent onset of iron deficiency anemia, you would also consider checking for any bowel cancer. So if you suspect GIT bleeding, fecal occult blood test is not the very valuable, but appropriate investigation will include gastroscopy and colonoscopy, small bowel biopsy, small bowel enema. But the main thing is that if you suspect patient having a possibility that they are bleeding from the gut, or patient is above 50-year-old, or there is a strong family history of bowel cancer in that patient, definitely we will send the patient for endoscopy and colonoscopy. So that's mainly for above 50 who has a sudden onset of iron deficiency. Okay? Now, sometimes you can ask, like, how to differentiate iron deficiency from anemia of chronic disease. The only way to know is doing this soluble transferrin receptor factor. This receptor factor will be increased in iron deficiency, but it will be normal in anemia of chronic disease. So if you want to rule out anemia of chronic disease and iron deficiency, then you would be doing this transferrin receptor factor. Now, this is a very good interpretation of iron studies. So in iron deficiency anemia, your iron will be low, ferritin will be low, but transferrin saturation will be low, but total iron binding capacity will be increased. The iron binding capacity means now there is lots of transferrin available in the blood. So it can easily bind iron. So that's why total iron binding capacity is increased. In thalassemia, everything will be normal. Okay? Anemia of chronic disease, iron will be low, binding capacity will be low, saturation will be low, but sometimes ferritin can be normal or increased. And hemochromatosis is another condition where the patient gets excess iron in their blood. So in that patients, everything will be increased except the total iron binding capacity. That's not important for today, but mainly these two is important, and bit of anemia of chronic disease. So remember this chart because they will give you a scenario, they will give you the lab test, and based on that, you need to decide what is the cause of cause of microcytic hypochromic anemia in that patient. So once you have got an idea that this is an iron deficiency, the next thing is increase the iron in the diet. Try to find out if there is any cause and correct that, and start the patient with iron supplement. So there are oral iron which comes with ferrous sulfate, commonly ferrograd C, which means ferrous sulfate added with vitamin C, which can increase the absorption. So most of the time, oral iron supplement will be your first choice. Now, it is, if let's say, even after giving the oral iron, patient having like very low ferritin, less than 5, getting into anemia, or patient is not able to tolerate the oral iron, then you can go for IV infusion. Remember, we don't give IM iron anymore, it will be IV iron. Also, if someone has got a known malabsorption like celiac disease, then for that patient, IV or parenteral iron will be ideal. Okay? And once you start the iron, patient needs to take the iron tablet for 3 to 6 months to replenish the store. So that's more or less all about iron deficiency. Moving on to thalassemia. Thalassemia is not very common in Australia and it doesn't come in exam. Very unlikely thalassemia like questions will appear in the exam unless they can just give you the question that I have done. All right. But otherwise, thalassemia is not very common and it is not usually asked in the exam. But you should get just a baseline idea. So thalassemia, it's an inherited condition and it is a autosomal recessive condition common in people from Mediterranean basin, Middle East, North and Central India, Southeast Asia, and South China. So it's not very common in this area. So thalassemia is mainly the hemoglobin chain synthesis is abnormal in this patient. And when hemoglobin chain is abnormal, that blood will be regarded as something abnormal by the hematopoietic system or the spleen. So when those abnormal blood cell will go through the spleen, even if it is premature red blood cell, it will be destroyed by the spleen, causing the hemolysis and causing the anemia. So that's mainly what happens. So this is a condition where there is abnormal hemoglobin chain synthesis, causing early destruction of the red blood cell, causing the anemia. Now, thalassemia is a vast topic. If you're from the Asian country, you know that lots of thalassemia things going on there, and we used to read a lot in our medical universities about thalassemia, right? Because it is very common. But in Australia, it's like I have never seen a thalassemia patient until now. So you can understand how rare it is. So in thalassemia patient, there might be two forms. One, that there is a heterozygous form and there is a homozygous form. So heterozygous form is the carrier form and homozygous is the main affected form. So because it is an autosomal recessive condition, to become thalassemia major, the child need two defective genes from both father and mother. So if father is a carrier and also mother is a carrier, which means both of them are thalassemia minor, then there is a 25% chance that their child can have the full-blown disease, which is the thalassemia major. All right? So in thalassemia major, because it is the active disease, that child can become quite sick. So they get all the symptoms of anemia, and the treatment is mainly blood transfusion. Whereas the heterozygous form means that maybe one parent was carrier and the child has got one carrier gene and child is just thalassemia minor. Thalassemia minor form is usually asymptomatic and they usually don't need any treatment. Okay? Now, how we diagnose it? So we do it by hemoglobin electrophoresis. And in the hemoglobin electrophoresis, it will give us an idea that there is some abnormal hemoglobin chain is high and the normal one is low. Nowadays, even a DNA screening is available. Remember one thing, that because these patients having increased hemolysis, their body already has excess iron. And on the top of that, they are getting blood transfusion. So already there will be excessive iron in their body. So you should not give iron in this patient. Okay. So iron is theoretically contraindicated in a patient with thalassemia. So treatment of thalassemia major is transfusion of packed red blood cell plus desferoxamine. Desferoxamine is the iron chelation treatment so that patient doesn't get enough iron accumulated in their body. If there is excessive iron in their body, what they will develop, guys? Yeah, that's right, Dr. Sneha, Dr. Fatima, hemochromatosis. And that is called secondary hemochromatosis. And that's also not good. Hemoglobin E. Now, many patients, especially from Southeast Asia, they have both thalassemia plus hemoglobinopathies. And the commonest hemoglobinopathies is hemoglobinopathies E. All right, so that's also one of the other thing. Doesn't come in exam, so don't worry about that. So mostly that's all that you need to remember from thalassemia. Next, macrocytic anemia. So macrocytic anemia, MCV will be high. And the common cause of macrocytic anemia is B12 deficiency and folic acid deficiency. Apart from that, someone who is alcoholic, having chronic liver disease, they can also get macrocytosis. There are some drugs which can increase the red blood cell size, like you can see phenytoin, then methotrexate, azathioprine, even alcohol. B12 deficiency. So B12 also comes from meat. So if someone is a vegetarian, they can also develop B12 deficiency. So if there is a blood picture showing patient having macrocytic anemia, and they're asking that what will be your next choice of investigation, that should be B12 folic acid level. All right. And if B12 level comes low, then you confirm that it is a B12 deficiency. Sometimes total B12 can be low, but active or hollow B12 can be normal. We look at the active B12 level in the blood picture. As long as their active B12 level is normal, that's fine. But if active B12 is also low, then there is a B12 deficiency. And one of the common thing, except lack of dietary meat, is an autoimmune condition called pernicious anemia, which is caused by lack of intrinsic factor due to autoimmune atrophic change and sometimes patient who has gastrectomy. So intrinsic factor is needed for the B12 to get absorbed in the terminal ileum. Okay, so intrinsic factor mainly comes from the gastric parietal cell. And what happens in pernicious anemia, it forms antibody against the parietal cell or against the intrinsic factor. And that antibody will destroy or reduce the production of intrinsic factor. And if there is lack of intrinsic factor, B12 cannot get added with intrinsic factor. And if B12 doesn't get added with intrinsic factor, it cannot get absorbed in the ileum. And then the patient develops B12 deficiency, and that is what we call as pernicious anemia. The same thing can happen with patient with gastrectomy, because again, they will not have enough parietal cell to produce this. So B12 found in normal diet, but only in foods of animal origin. So patient who has very strict vegetarian diet can develop deficiency. So causes of B12 deficiency, they have written in here. Sometimes even patient who takes a long-term PPI, they can also get it. We know about the clinical features that this patient will get macrocytic anemia. Now, remember one thing we discussed, that patient who develops long-term B12 deficiency, they can develop a complication in their nervous system. And that was that subacute combined degeneration of the spinal cord. What is the feature of this condition, guys, if you remember from our neurology class? What will be the main presentation in a B12 deficiency patient, apart from fatigue, tiredness? Very important to rule out if a patient comes with that symptom. Peripheral neuropathy. So they come to you with, yes, very good, Dr. Nahid. So globson is talking loss of sensation, or they come to you with a pins and needles or numbness in their foot. So any patient who comes to you with some symptoms like that, you should definitely check their B12 level and iron level. And the combined degeneration can come with, yes, it can come with ataxia, it can come with change in the sensation and all other things. They can get all the features of upper motor neuron type of palsy. Yeah. Okay. So you check the B12 and the B12 is coming low, then you will send the patient for intrinsic factor antibody level to rule out pernicious anemia. And the treatment is B12 injection. And normally patient needs to go for multiple injections to get the storage. Folic acid deficiency. So again, when you get a macrocytic anemia, you check both B12 and folic. And if the serum folate level comes low, then there is a confirmatory test, which is red cell folate. So serum folate, if it's low, that's the initial test. And then confirmatory test for folic acid deficiency is red cell folate level. If that is positive or that is low, then you can confirm it. And again, folic acid mainly comes from vegetables. So if patient is not taking a lot of veggies, then they can also end up getting it. Sometimes it can be associated with alcohol and other things. And if you get a folic acid deficiency, you will need to start the patient with folic acid supplementation. It is mostly present in fruits and veggies, especially citrus fruits, nuts, green leafy vegetables. And the treatment is oral folate, 5 milligram per day, and continue for 4 months. Okay, so far clear everyone with the micro and macrocytic anemia? Okay. Give it a read about anemia in children. Now, the main thing in anemia in children is iron deficiency. So sometimes it can even come to you with cognitive impairment in children. Now, high risk for iron deficiency in children is premature child, low birth weight child, child who takes a lot of cow's milk, and low iron containing food, exclusively breastfeed even after 6 months, and delayed introduction of solid food. So normally nowadays, even by 4 months, we advise the parents to start the solid. But if someone continue the breastfeeding for more than 6 months, did not even start the solid, that can definitely cause iron deficiency. And bottle feeding also can increase the risk of iron deficiency. The features that we will be looking for in a child in this age: irritable, lethargic, poor growth, shortness of breath. So for these patients, again, you need to introduce the iron containing solid between even at 4 to 5 months. Encourage breastfeeding. Avoid cow's milk in the first 12 months. Avoid excessive cow's milk up to 2 years. Use iron fortified formula and cereals. So there is a lot of things like infant, like they can't take meats. They can. So the pureed meat that you can start even from the age of 6 months. So that is totally fine. No problem with that. Okay. So advise the parents to start iron fortified meals. They can also start with a small chunk of meat. That's totally okay. Treatment will be mainly oral iron, which is ferrous gluconate, and continue for 3 months. Okay, so that's all about anemia chapter. Any questions, guys? Okay, moving on to the next chapter, and that is chapter 29, bruising and bleeding. So you can understand that we are mainly going through all the blood cell. So mainly three blood cell. We have got red blood, which is causing anemia, then white blood cell, which is mainly leukemia, lymphoma, and then platelet, which causes bleeding and bruising or thrombocytopenia. So coming to bleeding, bruising, so if someone coming to you with a abnormal bleeding, it is either coming from low platelet, low clotting or coagulation mechanism, or the blood vessel is not good enough. So there is always one of these three is not right, and that causes excessive bleeding. One of the commonest cause of acquired bleeding disorder is drug. Someone who is on blood thinners, like any of those warfarin, Clexane, heparin, so any oral anticoagulant, then aspirin, NSAID, this can also cause bleeding disorder. Always remember, if there is bleeding occurs spontaneously, then it is most likely platelet defects. So bleeding secondary to platelet is usually a spontaneous, associated with a petechial rash, and occurs immediately after a trauma or cut. So that's very important, that if there is lack of platelet or platelet is not functioning well, then the patient usually comes with excess bleeding immediately after a trauma, and those are very spontaneous. And bleeding can be usually from mucosa, like bleeding from the gums, menorrhagia, epistaxis, petechiae. So these are usually mucosal bleeding that we normally get in platelet defect. Whereas bleeding caused by coagulation factor deficiency, like let's say hemophilia A or B, which is factor 9 or 10. So in in coagulation factor deficiency, they usually doesn't happen spontaneously, rather after a trauma, and there will be a delayed onset in this case. So hemorrhage occurring 24 hours after a dental extraction, that's usually how coagulation factor deficiency presents. So if there is a clotting factor deficiency, ideally there will be delayed presentation. If it is a platelet deficiency, it will be a spontaneous and instant or immediate reaction. So causes of bleeding disorders. So bleeding disorder can result from coagulation deficiencies, platelet abnormality, either number is low or function is abnormal, or vascular defect, which is the blood vessel defect. So you can go through these vascular disorders, platelet disorders, and coagulation disorders. Like there are lots of causes, but the common ones are in vascular, there is Marfan syndrome, there is senile purpura, henoch purpura, vitamin C deficiency, steroid causing purpura. In platelet disorders, the most important is ITP, drug-induced thrombocytopenia, aplastic anemia. Then coagulation, mainly hemophilia A, B, and von Willebrand disease. Okay. Now moving on. So you can go through this initial part, have a read in your own time. Investigation. So let's say you have got a patient who has abnormal bleeding. Even after a minor cut, patient bleeds a lot. What would you do next? Your first investigation will be a full blood count. The full blood count will look for red blood cell, white blood cell, and platelet. So in that way, you would be able to know that if the patient has got any low platelet, and that is the cause of bleeding or not. Okay. And then you also do the basic coagulation studies, which means that you check for prothrombin time, you check for INR, and you check for activated partial thromboplastin time. So you mainly check the PT and APTT. Okay. So we are mainly checking the full blood count, prothrombin time, and activated partial thromboplastin time. Now, can anyone tell me what does this two means? Like what is PT and APTT? Okay. In a in a short time, in a simple way that we normally would look into it, that this actually look at the coagulation factor, if the coagulation factor is working or if the coagulation having any problem. Because with the platelet count, you check the platelet defect, and with the coagulation study, you are checking for coagulation system. Okay. Now, the PT and APTT, if we want to discuss that, prothrombin time mainly represents the extrinsic pathway and the common pathway, and APTT looks for the intrinsic pathway. Okay. Now, these pathways work together to have a clot after you bleed. Okay. So again, the prothrombin time represents the coagulation factors in the extrinsic pathway, and the main thing in the extrinsic pathway is factor 7. You know about all the 12 factors. So factor 7 is the main one in extrinsic pathway, and then there are other like common pathways as well. Whereas the APTT looks mainly in the intrinsic pathway, and intrinsic pathway is mainly the factor 9, 10, 11, 12. Okay, or mainly 9, 11, 12, and factor 8. Or you can remember factor 8, 9, because that's more important. So factor 7 is mainly the one with extrinsic. Factor 8, 9, 11, 12, that's the intrinsic. Okay, just remember up to this, we will come to that. It will come in handy later on. So basically these two tests, PT and APTT, looks how the clot is forming and how much time it is taking, how the PT will look at how the extrinsic factor is working, and APTT will look how the intrinsic clotting factor is working. Okay, that's the easiest way to say. Now, when we suspect that, let's say there is low platelet count, what would you do next? So if there is low platelet count, you look at the blood film. That means the peripheral blood film, to check for any kind of abnormality. Like if the platelet is looking bigger or any abnormal size. To check for any functional abnormality, we do the platelet function analyzer. All right. So that's mainly you would do if when you do the coagulation studies, if PT APTT is abnormal, then you check the specific factor. And we know that most common factor which gets abnormal is factor 8, 9, and 10. So you will be checking for factor 8, 9, and 10 if you suspect or if you find out any abnormality in the coagulation studies. So that's basically the step-by-step approach to start investigating this patient. All right, so first full blood count, then look for if the platelet count is low. If platelet count is low, then you know that it is most likely platelet disorder. You can check for the peripheral blood film and also platelet function to check if the function is also impaired. And then if that is normal, like platelet count is normal, then you check the coagulation status, which is mainly PT-APTT. If PT-APTT abnormal, then you check the specific clotting factor. Okay? And most of the time, if we can't find out any specific cause, then the last option would be to go for a bone marrow biopsy. Or bone marrow examination, sorry. So laboratory investigation checklist for easy bruiser, full blood count, platelet count, PT-INR, then APTT. These are the main 4 investigation. Henoch-Schönlein purpura. Very important. So Henoch-Schönlein purpura is a vasculitis, which is mainly we call it IgA vasculitis, and it is one of the commonest vasculitis in children. Can you remember another vasculitis which happens in children, especially children less than 5 years? Very good. Kawasaki. You guys are doing really good. Yes, Kawasaki disease. So Henoch-Schönlein purpura, it's a IgA vasculitis, and it is one of the commonest vasculitis of children. It mainly affects the small blood vessels, causing a classic triad of non-thrombocytopenic purpura, arthritis, abdominal pain. And many times it starts initially with a sore throat, and within a week, they start to get this triad. And the main finding is this palpable purpura. So you get palpable purpura in the lower legs, including the buttocks. Okay? Now, when we see this kind of bleeding spot, immediately we think that this is because of low platelet. But these patients who has Henoch-Schönlein purpura, their platelet count will be normal. That's why it is called non-thrombocytopenic purpura. And they will also complain pain in the knee joint, pain in the ankle joint, because that's what it causes, and abdominal pain, and sometimes even they can have hematuria. So the onset of HSP typically follows an upper respiratory tract infection, including a group A streptococcal pharyngitis. In this patient, when you get this, definitely you will check for full blood count, you will check the coagulation status, platelet count, everything will be normal. So their bleeding time, clotting time, platelet count, everything is normal. Okay? So it's common in children. Rash mainly involves the lower extremity like this, which is a palpable purpura. Large or long joints will be having the arthritis, abdominal pain, and hematuria. Okay, these are main symptoms. These patients can get some other complication like Anosclerotic purpura children can have intussusception, melena, kidney can get involved. So if we got a patient with this kind of symptom, our first investigation of choice will be full blood examination. And if we find their platelet count is low, then we would not think of HSP as our diagnosis. Okay. And also we can check the urine for any kind of blood or protein because these patients develop hematuria. So we want to make sure that their urine doesn't have anything like that. The treatment is symptomatic. There is no specific treatment unless patient having kidney involvement or having abdominal pain. Now remember, if a patient has got abdominal pain and tenderness, and the pain is a very sudden onset, you should look for intussusception. So do an ultrasound of the abdomen to rule that out. So let's say you've got a HSP patient and the child is having screaming episodes, okay? And during the screaming, child is complaining of pain in the abdomen, you would definitely rule out intussusception in that child. So do an ultrasound abdomen in such case. So patient usually gets better within months without any complication. But if child has hematuria, you will need to follow up the patients with repeated urine microscopy culture and kidney function. All right. So that's HSP. Next, moving on to platelet disorders. So platelet disorders, most important is ITP, which is immune or idiopathic thrombocytopenic purpura. And most important presentation is that they get spontaneous bleeding after a trauma or cut, bleeding from mucosa, and they can get petechiae or ecchymosis. Petechiae is a small bleeding spot which is not blanchable, and ecchymosis is like a bigger one. And definitely platelet disorders, platelet will be low. Reference, we know that it's more than 150 is normal platelet count. So for ITP in children, most of this usually comes after a recent viral infection. So they get a viral infection and followed by that, they come to you with a easy bruising. They can come to you with bleeding from gums, epistaxis, menorrhagia, but otherwise everything will be fine. No systemic feature like no fever. They will not have any features of hemolysis such as splenomegaly. The only thing positive in this patient is isolated thrombocytopenia. So if you get a child having a recent viral illness and now coming to you with easy bruising and bleeding from gum or nose, and then you check their platelet count and it is low and everything else is normal. They don't have any hepatosplenomegaly. They don't have any low red blood cell or low WBC count. That is when you think of ITP. Okay. So now ITP or idiopathic thrombocytopenic purpura, there is a bit of more to know from here. So if you go to RCH, they have a very good discussion about ITP. So I want you guys to read that. But as part of management, most of the time, we don't need to do anything for this group of patients unless patient having a risk of spontaneous bleeding. So we say that only time you need to send the child to the hospital with ITP if the child having a active bleeding at the moment, like the child is actively bleeding and bleeding is not getting stopped, or if the platelet count goes less than 30. So if platelet count less than 30 or patient is actively bleeding, that's the only time you send the child to the hospital, and many times they might need a platelet transfusion, or the treatment is mainly with IV immunoglobulin or steroid. So not platelet transfusion, sorry. So mainly you will need to treat these patients with IV immunoglobulin or steroid. Okay. If between these two, they want you to choose, IV immunoglobulin is the main treatment. And the prognosis is good for this ITP. because most of the time it is self-limiting. 90% cases, it will be totally resolved in 6 months. Any questions so far, guys? So the treatment is, unless patient is actively bleeding or platelet count less than 30, no treatment, just wait and watch. If the criteria fulfills, patient bleeding or less than 30 platelet count, the child will be sent to hospital for a IV immunoglobulin or a steroid. There is a bit of more criteria, so have a read of from the RCH guideline for ITP, okay? But gist is this. Moving on to coagulation disorders. So clotting factor deficiency causes the coagulation disorder, and the presentation is a bit delayed. So patient got a trauma, and then they come to you with a bleeding into the muscle or bleeding into the joint. So most common presentation of coagulation defect is muscle or joint bleeding. So hemarthrosis or hematomas. Now, the common causes of coagulation factor deficiency are hemophilia A and B, and also von Willebrand disease. So these three mainly is important for your exam. But as we know that there are 12 clotting factors, but the main one that we want to remember is factor 8, which is anti-hemophilic factor A, factor 9, which is anti-hemophilic factor B. Very important for exam is von Willebrand disease. Very important. And it can be quite confusing in the exam sometimes. So it is the most common disorder of hemostasis. It's a mild problem with excellent prognosis. Now, if you look over here, that von Willebrand disease is an autosomal dominant inheritance. So, which means that either the father or the mother had the genetic abnormality, and even with one abnormal gene from either parent, the patient can get a von Willebrand disease, right? So that's how autosomal dominant inheritance work. So both men and women can get this condition equally. Now, even though this is a clotting factor problem or coagulation disorder, the presentation is similar to platelet disorder. So patient come to you with mucocutaneous bleeding. They come to you with like bleeding from the gums, epistaxis, menorrhagia. So those are common symptoms, not hemarthrosis or hematoma like hemophilia. So that's where it gets confusing in the exam. All right, but they make it sure that you understand what they're talking about. They will give you some lab findings, and then you will know that this is von Willebrand they're talking about. So in this patient, because of the clotting factor is not working properly, the bleeding time will be high, so prolonged bleeding time, but the platelet count is normal. So why there is problem? Like the problem is defective platelet adhesion at the site of trauma combined with factor 8 deficiency. So there is a very important thing to know. So I'll share a picture with you. Just give me one second. I'll just stop the sharing and I'll show you a picture that how this happens. Just one second. I'm just trying to find out a good picture. Okay, let's show you this one. If you look on this picture, you can see that how mainly this happens. So have a look that, let's say that there is a cut in a patient's body somewhere. So when there is a cut, then there will be first thing that it will cause is endothelial defect. And that will be sensed by the platelet. So platelet is supposed to get attached to this endothelial defect. So platelet will come and try to stop bleeding. And then let's say it's not working. Then what will happen that you can see that with the platelet, the von Willebrand factor and factor 8, these two, usually they are interconnected. So this factor 8 and von Willebrand factor is supposed to get connected with the platelet and start the clotting cascade. Now, the problem with von Willebrand factor is that this platelet van Willebrand factor adhesion doesn't happen because there is no von Willebrand factor available in the blood. Okay, so because of lack of von Willebrand factor, it cannot get connected or cannot get connected with the platelet. So clotting cascade also doesn't start. So the patient bleeds. Okay, because von Willebrand factor is not getting added. Factor 8 is not also working because of that. Okay, now factor 8, does it actually manage the intrinsic pathway or extrinsic pathway? Anyone knows? Remember we discussed? So if you see here, the intrinsic pathway and the extrinsic pathway over here. Okay, so see this one, the intrinsic pathway is mainly managed by the factor 8, 9, 11, and 12. So when there is lack of von Willebrand factor, there is lack of factor 8 also, and that's why the intrinsic pathway will not be activated. So what will happen to APTT in this patient? APTT will be prolonged, but the prothrombin time or PT will be normal. So just to like making sure that you understand, we have to go through all of this. So basically, that's the main problem with a lot of candidate doesn't even understand why APTT getting prolonged, why bleeding time getting prolonged, why like the PT is normal in this patient. So this is why. And why the patient getting mucocutaneous bleeding, even if the platelet is normal. Because you need the factor 8 with von Willebrand factor to get added to the platelet to mainly stop the bleeding. Because now there is normal platelet, but it's not actually able to work because of lack of von Willebrand factor. So that's why, even though it is a coagulation disorder, it can present as a platelet disorder kind of bleeding, which is mucocutaneous bleeding. Okay, so you've got a patient who is having bleeding from gums, bleeding from nose, easy bruising, and then you did the blood count. You found that their platelet count is normal, but there is clotting abnormality. And you found that their bleeding time is increased, PT is normal, but APTT is elevated. Then you would be concerned that is it a hemophilia or is it a case of von Willebrand disease? So then you will test for both. So you will be checking for von Willebrand factor. So you will see positive von Willebrand factor antigen. You will be checking for factor 8 to check for hemophilia and factor 9. So that's when you will get the diagnosis. Does it make sense, guys? So you can see menorrhagia epistaxis is common. Hemarthrosis is rare in this patient. So no specific treatment is needed. Avoid anything which can increase bleeding. And there are some treatment that is also written quite well in RCH. So let's have a look. So you can see there are three types of von Willebrand disease. The management. So tranexamic acid is mainly given if someone having mucosal bleeding, and that is usually the initial treatment of choice. So if a patient with von Willebrand disease is actively bleeding, then to stop the bleeding, you can give them tranexamic acid. Then there is the option of desmopressin. Desmopressin is not recommended in children below 3 years old because it can cause hyponatremia and seizures. So in this type of treatment is usually needed if patient with a known von Willebrand disease is going for some kind of procedure, like patient will go for a dental procedure, then you can give this desmopressin prophylactically to minimize the bleeding. So when required, pre-operatively administer this desmopressin 30 minutes before the procedure. Now, the only time we will use the factor 8 von Willebrand factor replacement if a patient is actively bleeding and not getting controlled with desmopressin. So this is the step-by-step tranexamic acid for mucosal bleeding. Then if patient needs pre-operative prophylaxis, that will be desmopressin. If desmopressin is still not able to control bleeding, the last option is factor 8 von Willebrand factor replacement. Okay. And as we are discussing about ITP, you can also go through the ITP from RCH. So it's always risk categories is important. The treatment is based on how risky they are. So a patient having many bruises, painless petechiae, that means not actively bleeding, outpatient treatment can be done without any treatment, just outpatient management and review. Moderate, if patient is having epistaxis, staying more than 5 minutes, these are all active bleeding. So if patient is actively bleeding, sometimes may need hospitalization, and the hospital treatment will be first line steroid. If steroid is poor response, then IV immunoglobulin will be the treatment. Okay. Now, in case of severe, like patient having bleeding internally, then you will need to start with IV immunoglobulin plus IV steroid, or even sometimes platelet transfusion might be required. So that is the step-by-step treatment for this condition. So normally we'll say that if patient is not actively bleeding, just bruising, outpatient treatment. If actively bleeding but not internally bleeding, then oral steroid followed by IV immunoglobulin. If severe, which means internal bleeding, bleeding into brain, lung, muscle, joint, then you have to start with IV immunoglobulin. Okay? Does it make sense for everyone? The next is hemophilia. So hemophilia is a coagulation disorder, and hemophilia A is deficiency of factor 8. So deficiency of factor 8 will cause this. This is the X-linked recessive, so only the male will be affected, no female. Female might be carrier, but never affected. Not never, sometimes they can be, but mostly male will be affected in here. And you know that the main presentation will be hemarthrosis or hematoma. The investigation will be the same. So your PT will be normal, but APTT will be prolonged in this patient. And once you think about it, the treatment will be recombinant factor 8 concentration. All right, so that's all about bleeding and bruising, guys. Any questions so far? Yeah, if patient is not actively bleeding, no need of any treatment. Platelet transfusion is the last option. Even after IV immunoglobulin, still not like patient's platelet is quite low, patient actively bleeding, life-threatening, then only platelet transfusion. Okay, coming to the white blood cell related disorders, leukemia. So leukemia comes in exam, it doesn't come, but only just a superficial knowledge will be enough. You don't need to go in too much detail. So leukemia is a white cell disorder where there is abnormal proliferation of WBC, can be mature WBC or immature WBC getting abnormally proliferated. So let's discuss a little bit about leukemia, and then we will come in here. So if we discuss about leukemia, so in leukemia patients, what normally happens that these patients, their main presentation can be just a constitutional symptoms. That means they can have features of anemia, tiredness, generalized malaise. So, sorry, we'll just change the color. Okay, in leukemia patient, based on what kind of leukemia it is, the symptoms and sign might be different. Okay, so first of all, leukemia means abnormal proliferation of WBC. So WBC count will be very high. Now you know that there are lots of WBC. There is neutrophil, lymphocyte, monocyte, eosinophil. Lots of WBC type are there. In leukemia, we are mainly looking at neutrophil and also lymphocyte. These are the main two that we look for. And also we look for some other smaller one like monocytes and everything, but mainly neutrophil and lymphocyte will be our main thing that we look into. Okay, now there are mainly four different kind of leukemia that you need to know. So one, you have got, so let's talk about acute leukemia and chronic leukemia. Okay. In acute leukemia, we have got acute lymphoblastic leukemia, where lymphoblast will be abnormally proliferated. And then we have got acute myeloid leukemia, where myelocyte will be the abnormal white blood cell, which will be proliferated. Acute lymphoblastic leukemia is mainly common in children. Okay, all other leukemia is common in adult. Chronic leukemia again is divided into CLL, so chronic lymphoblastic leukemia or chronic lymphocytic leukemia. And then we have got chronic myelocytic or chronic granulocytic leukemia. So in this case, again, these are chronic. That means it's been happening for a long time. So AML, CLL, CML, all are mainly common in adult patient. Now, patient who gets lymphoblastic or lymphocytic leukemia, their main presentation can be generalized lymphadenopathy. Whereas patient who has myeloid leukemia, their main physical examination finding will be hepatosplenomegaly. Okay? Doesn't mean that ALL patient cannot have hepatosplenomegaly. They can, but the main presentation is for ALL or CLL, lymphadenopathy. For AML, CML, hepatosplenomegaly. As part of symptoms, they will get, leukemia patient will get frequent infection. Even though they have increased WBC, these are immature WBC and doesn't work like how it should be. So they will get increased infection. On the top of that, leukemia patient at some point they become anemic, so low hemoglobin. So features of anemia will be there, tiredness, fatigue, malaise. They get low platelet count, so they will have increased bleeding tendency, bruising, bleeding, etc. So that will be the main presentation for leukemia. Okay. And let's say you thought about leukemia in a patient. What will you do first? You will do a full blood count. The full blood count will give you an idea that there is increased amount of WBC. And it will also give you an idea that what type of WBC has got abnormally elevated. When you do that, when you get something like that, then definitely you will think that, well, something is wrong, that it might be a case of leukemia. When you think of leukemia, you can send the patient for leukemia marker. And leukemia marker sometimes will be able to give us an idea that what type of leukemia it is. Is it lymphocytic or myelocytic? You can also look at the peripheral blood film. And with the peripheral blood film, you can also get a bit of idea that what type of cell has got increased. Is it lymphoblast? Is it myeloblast? So lymphoblast, myeloblast, is it lymphocyte or myelocyte? So based on that, you will get an idea that what type of leukemia it is. And then you do a confirmatory investigation. Okay, and we will come to the confirmatory investigation just in a bit. So we're talking about general constitutional symptoms of anemia, infection, easy bleeding, bruising, and leukemia patient can come to you with bony pain or joint pain. Sometimes AML patient can have gum or gingival hypertrophy. Sometimes leukemia patient can have sternal tenderness. So those are also quite common. Signs you can see in here, bony tenderness, especially sternum, liver, spleen, lymph node can get enlarged, gingival hypertrophy, and other symptoms. So full blood examination and peripheral blood film will be the initial choice of investigation, and followed by you will be doing, like, sometimes we do bone marrow, sometimes we do PCR, sometimes cytogenetics. Now, to know a little bit more about the leukemia, I want you guys to go through med bullets. And med bullets usually will have a little bit more understanding, especially about the confirmatory investigations. Like, let's say we talk about ALL med bullets. So I want you guys to go through a little bit from here, and they also have some of those questions. You should be able to get some idea. So if you look over here, the evaluation is the main thing that I want you guys to read. So when you think about leukemia, you did a full blood count and you did a peripheral blood film. Peripheral blood film showing that patient having increased lymphoblast. So then you think that, well, it must be acute lymphoblastic leukemia. So then you confirm it by doing a bone marrow biopsy with cytogenetics. And when you do the bone marrow with cytogenetics, it will confirm the diagnosis. Okay. The treatment is chemotherapy. So you only need to know what is the presentation, what is your best test and most accurate test, and what is the treatment. And this comes in exam. Then we are coming to acute myelogenous or acute myeloblastic leukemia. So you can go through these questions and everything. As you can see, median onset above 65. So it's mainly elderly patient who gets it. So initial test, same, peripheral blood film and full blood count. And in acute myeloblastic leukemia, again, you will get more than 20% myeloblast in the blood film. The most accurate test is called flow cytometry. You can also do a bone marrow biopsy with cytogenetics, but the most accurate is flow cytometry. So you need to remember this because they give these kind of questions in the exam. Treatment is chemotherapy followed by bone marrow transplantation if it is possible. So that's ALL and AML. Now coming to CLL and CML. So chronic lymphocytic leukemia, CLL. CLL is also common in adult patient above 60, and it is the most common form of leukemia in adults. So ALL is most common in children, and CLL is most common in adult. The symptoms are pretty much same. Now, if you do the investigation, definitely WBC count will be very high, with more than 80% can become lymphocytes. That's why it is called chronic lymphocytic leukemia. And in this patient, most accurate test is also flow cytometry. If you do a peripheral blood film, you can get a smudge cell in this patient. So these will be sometimes a clue in the exam question. Okay, so full blood count with a peripheral blood film followed by flow cytometry is the main investigation. Treatment. Now this is important. You only treat a CLL patient if they're symptomatic. If they're asymptomatic, you don't treat them. And the treatment of choice is fludarabine. Last is chronic myeloid leukemia, CML. Now, in CML, the main pathophysiology is lack of a chromosome is called Philadelphia chromosome. And that is the main pathophysiology behind this CML. So CML patient, again, you do a blood count, you will find out there is lots of immature granulocytes. So myelocyte, metamyelocyte, this will be elevated in here. And also You can start with bone marrow biopsy, but the main accurate test is cytogenetic analysis or FISH showing Philadelphia chromosome. So initial is blood count with peripheral blood film, and the most accurate is cytogenetic analysis with Philadelphia chromosome positive. Medical treatment is mainly chemotherapy, and sometimes even stem cell transplantation can be also tried with, and that is the curative treatment. Okay, so I want you to guys to maybe making a note from these med bullets regarding these four leukemia, and that will be very important for exam. Any question, guys? Okay, so that's actually what we normally would discuss in hematology. I'm taking a 5-minute break, and after that, we will start with the renal system. Thank you. All right, everyone, let's start again. So now we are going into nephrology. So for nephrology, as I said, already half of them are done somewhere in our course, such as we discussed urinary tract infection in pediatrics, in gynecology. So UTI, nothing to discuss from my end, but there is a chapter 16, which is urinary tract infection, which you should go through just read once, but most of these are already discussed in our classes. So that's one chapter. And the other chapter that normally I discuss is chapter 65, which is urinary disorders. So let's continue with this one. So urinary disorders, first of all, there are lots of urinary conditions, right? So the main one that comes in exam is hematuria and also sometimes nephrotic syndrome, nephritic syndrome. And those are already has been discussed in pediatrics. So main focus would be hematuria, and that comes a lot in the exam. So hematuria means presence of blood in the urine, can be frank bleeding. So patient can come to you saying that I can see blood coming out with the urine, or you did a urine microscopy or dipstick and you found there is red blood cell in there. So that's microscopic hematuria. And there are lots of causes of hematuria. So you can go through this. When we think of microscopic hematuria, that means patient did not see any blood, but it mainly came with the test. So the bleeding can come from glomerular, which means from the kidney. And the common cause of hematuria from the kidney is IgA nephropathy and thin membrane disease. Could be urological, that means non-glomerular, could be bladder cancer, BPH, even a stone. Macroscopic hematuria occurs in 70% people with bladder cancer and 40% with kidney cancer. So that's why it is very important to rule out. So you can read the initial history and the causes. So hematuria can be due to infection. So even a UTI patient can present with hematuria or blood in the urine. Kidney stone, ureteric stone, bladder stone can come with hematuria. Then sometimes some other condition like if especially cancer, so nephrological cancer like kidney cancer, like renal cell carcinoma, urothelial, bladder, pelvis, ureteric cancer, prostate cancer, any of these can present with hematuria. Glomerulonephritis, which means post-streptococcal or IgA nephropathy can be a cause, and there are lots of other causes which you can go through in your own time. Investigations, and that's the main thing, that how we investigate a patient who has hematuria. So I will go through what JM has written, and then we will go through some other guideline. So first of all, you have, like, let's say a patient come to you with some kind of kidney condition, or patient says that patient have noticed blood in the urine. So first thing is dipstick, that means which you can do it bedside. So you did a dipstick test and you found, yes, there is red blood cell. Then you send it to the lab for urine microscopy and culture. Urine microscopy will be able to confirm if it is red blood cell, and it also can say if there is any red cell cast or dysmorphic red cell, which will indicate it is coming from the kidney. And also it can say that if there is any urinary tract infection. So microscopy culture is very helpful in this case. Sometimes we also do urine cytology. Remember, cytology and urine microscopy culture is different. Microscopy culture mainly looks into red cell cast, red blood cell, and also infection. Whereas cytology mainly looks at the blood cell or cancer cell in the urine. So only time you would be doing a cytology if you suspect a cancer. And then we do some blood tests to check the kidney function, inflammatory marker, those are fine. And then there are some radiological investigations such as intravenous pyelogram, which is the most commonly done, ultrasound, CT scan of the kidney, ureter, bladder. So these are the common imaging that we do in a hematuria patient. Now, I'm going to talk a little bit more in detail about it. So let's talk about hematuria, RACGP. So this is a guideline which is a bit new guideline for management of hematuria. As you can see, it's 2021. So you should read this guideline in detail. And they talked about what are the etiology and everything, which you can go through. History, risk factors of malignancy in patient with hematuria. So always remember someone who has a occupational exposure of dye, benzene, aromatic amines, like patient who used to work in these industries, they have a high risk of bladder cancer. Smoking history, anyone, especially male above 40, gross hematuria, family history of bladder or urinary cancer, they are high risk patient. Initial investigation. So this is where it is important to remember. Before you refer a patient to urologist, initial investigation should be done. So you will do first of all, any patient who has hematuria, especially painless hematuria, your first investigation is you do a dipstick followed by urine microscopy and culture. If there is a suspicion that or the urine microscopy culture says that the urine has been contaminated. If it is contaminated, you have to do a repeat urine microscopy and culture. If it is a UTI, then that's it. That means patient had a UTI and that caused the bleeding. So you will need to make sure that after UTI has been resolved, you will need to repeat the urine microscopy culture to make sure there is no more any blood in the urine. In between that, you can also do some biochemical investigation, which means you do some blood test, check the kidney function, check the coagulation factor, making sure there is no biological abnormality. And then you'd do two things. One, you'll do a CT IVP or ultrasound based on the patient. CT IVP, which is the CT intravenous pyelogram, is the gold standard for urinary tract malignancy. Now, this is mainly needed in patient who has high risk, like male above 40 or male above 50, who is a smoker, history of occupation exposure, and other risk factor. Then you would definitely do a CT IVP for them. But younger patient, less than 50, those who doesn't have that much of a risk factor, for them ultrasound is sufficient. And also for female patient or a pregnant patient, especially pregnant patient, you would not go for a CT, you would go for an ultrasound. Along with the CT IVP, you would also arrange a urine cytology. We normally send 3 samples of urine cytology, and we look for if there is any cancer cell in there. So anyone having this hematuria, they needs to have this work first. So you do a urine microscopy culture, you do the CT IVP, you do a urine cytology. These 3 is must. So this is what the chart all about. You've got a patient with hematuria, you have taken history, you have done the examination. First, rule out UTI. So make sure you do the urine microscopy and culture. Then, let's say it is not UTI. Is it a microscopic hematuria or macroscopic hematuria? If it is macroscopic, that means gross hematuria, that is always a high risk. So for that patient, you do a CT IVP or ultrasound, plus a cytology, and then refer to urologist because they might want to do a cystoscopy to look into the bladder. Again, any gross hematuria, whatever is the age, better to go for whole imaging. So CT IVP plus a urine cytology, followed by referral to a urologist for cystoscope. And these are the risk factors they have given. If it is microscopic, then you check the risk. If it is low risk, in that patient, microscopic hematuria, low risk for cancer, you can even just consider doing repeat microscopy to see that if the bleeding persists, especially if they don't have any risk factor of a cancer. But if risk factor is there, even if it is microscopic hematuria, the full investigation will be needed. Does it make sense, guys, like what I'm trying to say? And if you suspect glomerular condition, like you have found proteinuria, you have found dysmorphic red blood cell or red cell cast on microscopy, then you will need to send the patient to a nephrologist. So this is all that you need to remember for hematuria, and that is what comes in exam. Now, one of the cause of hematuria is bladder cancer. 90% is transitional cell carcinoma, and main presentation is hematuria. So it's not needed to remember. The treatment doesn't come in exam. Now, glomerulonephritis. So glomerulonephritis is what we have already discussed in the class. So we discussed the PSGN, the IgA nephropathy, all have been discussed. We also discussed about nephrotic syndrome. So you all know about all of this. Incontinence. We haven't discussed urinary incontinence yet. So urinary incontinence also comes in exam. So incontinence means inability of the patient to hold the urine. There are mainly 3 or 4 types of incontinence. So we have got stress incontinence, urge incontinence, mixed incontinence, and there is a condition called overflow incontinence. So urinary incontinence is a distressful condition for a female. It's mainly happening in elderly population after menopause, and both stress and urge incontinence is common. So stress incontinence is if the patient has got weak pelvic floor muscle, whenever they give a cough, laugh, sneezes, anything which increases intra-abdominal pressure, they will leak some urine at that time. So patient will say that every time I laugh or every time I strain during passing bowel, I get a little bit of leak of urine. That is stress incontinence, and most common cause is pelvic floor muscle weakness. Whereas urge incontinence is mainly that the bladder muscle, which is detrusor muscle, is overactive in this patient. So even though there is a small amount of urine accumulated in the bladder, the muscle is quite hyperactive, and it always gives sense to the patient that you need to go. Sometimes the urge is so much that even before going to the toilet, they start to leak urine on the way to the toilet. So that's urge incontinence. Urge incontinence can be due to pelvic floor muscle weakness, can be also due to some neurological problem like stroke, diabetes causing neuropathy, multiple sclerosis. So any of the spinal cord or like a upper motor neuron type of condition can also lead to urge incontinence. The mixed incontinence is someone who has got both stress and urge. Okay. So how we assess a patient who has incontinence? A lot of time, only thing that can cause this is a medication. So look for any medication which can aggravate incontinence and see if we can change it to something else. But as part of investigation, everyone who comes to you with the incontinence, you need to first do a urine microscopy and culture to rule out infection. Followed by urine microscopy culture, you can also do a urinary tract ultrasound to check how much urine they're retaining, like if they're actually having any urinary retention or not. And then if you are doubtful about the diagnosis, then you can also send the patient for a urodynamic studies to confirm the diagnosis. So confirmatory is urodynamic and initially is microscopy and culture. Management. So once you know what type of incontinence it is, the management of stress incontinence starts with at least 3 to 6 months of pelvic floor muscle exercise. So you can even send the patient to a physio who can actually teach the patient how to do the pelvic floor muscle strengthening. If that doesn't work, then mainly refer the patient for a surgical treatment. If it is urge incontinence, the initial treatment would be bladder retraining, including a pelvic floor muscle therapy. So you have tried the initial treatment, did not work. The second line treatment is an anticholinergic medication. So anticholinergic medication can retain urine, and that will help a patient who has incontinence. So you can use any of these oxybutynin, solifenacin, or tolterodine. These are the anticholinergic drugs that we use. Still not working, the last option will be surgical treatment. Okay, but before surgical, nowadays they also do few others, like see that botulinum toxic, neuromodulation of the sacral nerve. So there are few others that can be tried as well. So we have got stress and urge incontinence treatment. Next, uterovaginal prolapse. So many patients who develops incontinence, especially elderly women, they also can develop prolapse. And prolapse is a very, very common finding. And they will come to you that they can feel something is coming down or they feel a heaviness in their vagina. So this kind of patient also has incontinence associated with prolapse. So prolapse, it could be uterus and vagina getting prolapsed. It could be associated bladder getting prolapsed, urethra getting prolapsed, rectum getting prolapsed. So any of these can be there. So first of all, as part of management, the pelvic floor muscle exercise will be the first thing. So lifestyle modification will be the first thing that will be tried, especially in mild prolapse. The second line would be putting a vaginal pessaries, and the pessaries will be able to keep, keep this organ in place. If even after pessaries, patient is not getting any better, or the patient actually wants surgery, and patient is having quite distressful life, young patient fit for surgery, and for them, a reconstructive pelvic surgery will be indicated. Okay, so that's pretty much everything that we need to know from the prolapse and incontinence. All right, any question, guys? All right, so that's pretty much everything that we would discuss from these conditions, that especially the hematology and renal. Do you guys have any questions from these two topics? And this is not the end of your course. We still have few things left, so don't worry. Your last class will be most likely on 9th of August. So you'll get a schedule tonight. The question that you have asked, Ume, looking at the question, lymphoma is not very common in a child. And rash can appear actually in both leukemia and lymphoma. So I would rather choose leukemia in this child rather than lymphoma. And Dr. Sana, we already discussed the drugs. So cocaine, heroin that you have written, that has been discussed in psychiatry. And the others we can discuss in the left out topics. That's prostate cancer will be discussed anyway. We will discuss infectious diseases in the last two class. So that's fine. Can you send me some COVID related questions? Because I need to know what's coming in the exam before discussing COVID, because there's a lot to discuss. So why not you guys send, or maybe even, no, just send me, Dr. Ume, I will keep it with you, or Dr. Sana. Just send me few questions that is coming as from the COVID. Okay? Then we can discuss it. It should not be pending if you are posting in your Facebook group. Your Facebook group, you have full access. There is no pending for your Facebook group. But if you want to post in the main group, then you will need that pending thing. But you don't need to post in the main group or official group. Just do it in your own group. Can we continue recall classes after last class in August? So if any of you want to continue the recall classes, we always allow our ex-students to join the recall sessions, but there is a subscription fee for that. We will post it in your Facebook group just before we finish your course. Okay, so there will be a post. I believe we should be able to give it next week so that you are aware of it. And yes, you can join those sessions. A lot of our students join it. And I would definitely say if your exam is this year or early next year, definitely continue the recall classes. It's super important. All right, guys. So I will stop it here tonight, and you will don't worry about the topics that you are discussing. It will be discussed in the last few classes anyway. So we normally discuss most of the important things. So it should not have anything that is not been discussed. It has been discussed already, Dr. Kanchana. Anything that has been discussed, we can't discuss this multiple times. That is because we have still a lot of things to go through. Dr. Kanchana, cervical cancer has been discussed in gynae class. Breast cancer has been discussed in gynae. Colon cancer has been discussed. So those are the main screening has been discussed already. It will not be rediscussed because we don't have that time anymore. And we will discuss about the revision techniques at the end, Dr. Shaba. Okay, not at the moment. So Dr. Mehra, I think we talked about this. New guideline is still not the one that is being followed in Australia. You will be following the 9th edition for colon cancer guideline, which means the old one. All good. So thanks everyone. I'll post the remaining classes just in few minutes and you can have a look and go from there. Okay. Thanks everyone. Have a good night. Take care. Bye.